this evening we're going to be reviewing certain objectives regarding ovarian cancer, specifically the incidence, origin, and management, to discuss genetic testing, who, why, what, and my perspectives of the future. I want to start by saying how excited I am to be invited to this special webcast, and I'm just excited for everyone on the phone too. So feel free to call in with your questions. We've already got some great questions, and hopefully this will be informative to you all. So I love showing this slide to just get an idea of the landscape of cancer cases in the United States. These numbers are just staggering. In 2017, there'll be almost 1.7 million new cancer cases, and over 600,000 people will die from cancer-related deaths. To put this into perspective, ovarian cancer is a relatively rare cancer, but it's a cancer that's near and dear to many of our hearts as we treat women who have this disease. It's currently the 11th most common cancer in women, and compared to that staggering number I showed you above, it's not that common, as I've mentioned. There's estimated to be approximately 22,000 cases this year, and approximately 14,000 women will die of this type of cancer, and that is way too many. The lifetime probability of dying of ovarian cancer is about 1 in 106, so it's again relatively low, but we're doing everything we can to improve cure rates for these patients, and that's part of our talk today. I also want to show you this information because I think it's very exciting as well. As you see, the incidence of ovarian cancer in the United States has continued to decline over time. I hope you can see the pointer on my screen. So here we are in 1975, and this is the rate per 100,000 women in the population. And you see it was relatively plateaued for quite some time, but we now are seeing this downward curve here. This era right here is when paclitaxel started being used to treat ovarian cancer patients. Some of you on the call may either have been treated with this drug or have family members who've been treated with this drug. And then now we're moving to this time period in 2013. The incidence rate, as shown by this graph, has slowly declined over 20 years, and we're hopeful that it will continue to decline. And I'm going to talk about one of the ways that we can ensure that happens. In 2013, there was approximately 200,000 women living with ovarian cancer in the United States. And one of the reasons that we're seeing this is because women are living longer with ovarian cancer. This slide demonstrates the risk factors for ovarian cancer. Many of you may already be familiar with these risk factors. On this side here, we have increased risk factors, such as the BRCA1 or 2 gene mutation carriers. And many of you may be familiar with this gene mutation. Angelina Jolie came out several years ago and made it known that she does indeed carry one of these gene mutations and has had prophylactic surgeries to try to prevent breast, ovarian, and tubal cancers. And her being very upfront with this genetic inherited mutation, I think, has helped other women realize that they need to be tested. Another syndrome you may not be as familiar with is Lynch syndrome. This is a constellation of not only ovarian cancers, but endometrial cancers, colorectal cancers, certain types of cancers involving the bladder tract or genitourinary system, small bowel cancers, and stomach cancers. Even if somebody doesn't have one of these mutations, if they have a family history of ovarian cancer, but negative testing, they do have a small increased risk. It's relatively low, approximately 3%, but still something they need to be aware of. Because in the general population, the risk of ovarian cancer is approximately 1.4%, so that's very low. If someone has a history of endometriosis, they may be at risk for certain types of ovarian cancer, specifically clear cell and endometrioid cancers. Increasing age can also increase the risk, as well as infertility, hormone replacement therapy, and there's some new information about obesity may increase the risk of certain types of ovarian cancer. On this other side, we have some factors related to decreased risk. So if someone has a history of oral contraceptive use, that actually reduces the risk of ovarian cancer. Histories of pregnancy, breastfeeding, or if they've had their ovaries and tubes removed, that can reduce the risk of ovarian and tubal cancers almost down to 0%, but not quite. So even if the ovaries and tubes are removed, there's a very small risk that someone can still develop this type of cancer, but it's probably in the 2% range. If someone's undergone a hysterectomy or tubal ligation, that also reduces the risk. This graph shows the incidence by age in the United States. Remember, we talked about increasing age being a risk factor. And as you can see here, most women who develop this disease are in their 50s or older, and the median age of diagnosis of ovarian cancer is 63. This pie chart demonstrates that there's several different types of ovarian cancer. They're not all the same. And for instance, here you see only the epithelial ovarian cancer subtypes that we're going to concentrate on today, but there's also germ cell cancers or stromal cancers of the ovary. The largest chunk of this pie is identified as high-grade serous cancers. You can see here this blue part of this chart. The majority of epithelial ovarian cancers are these high-grade serous cancers. They do tend to be more aggressive, but some of these cancers also tend to be more sensitive to chemotherapy. Some other examples of ovarian cancers include mucinous cancers, endometrioids, which can be either low-grade or high-grade, clear cell cancers, and low-grade cancers. I want to turn your attention over to this little figure here of the female reproductive tract. We now think that most of these ovarian cancers are probably tubal cancers. Here is the fallopian tube right here. I'm trying to outline that with my arrow. I hope you can see it. And they think that these lesions in the tube called stick lesions, known as serous tubal intraepithelial carcinoma, actually these small cells in the tube slough off the tube onto the ovary or into the peritoneal cavity and implant on the ovary and these adjacent structures and develop into larger cancers. So the ovary may be the poor innocent bystander here that just gets blamed for everything, but the actual cancers may be coming from the tube. This seems to be true for high-grade serous and low-grade serous cancers. The other thought here is that the lining from the uterus, which I'm outlining right here with the arrow, these endometrioid type cells can actually slough off through the tube through a specific process called retrograde menstruation and can implant on the ovary and pelvis and lead to cancers. There's something you may be familiar with that we mentioned as a risk factor, which is endometriosis, and these types of lesions typically develop into clear cell or endometrioid cancers. And then the mucinous cancers may come from glands in the cervix or elsewhere. They're just not quite as sure about where the mucinous cancers come from. I'm going to move on to this figure to just highlight not only do some of these cancers come from different places, but sometimes these cancers have different types of molecular alterations. So these high-grade serous cancers, HG for high grade, classically was known as type 2 cancer. I think this is a simplistic view. We now recognize that even among these high-grade cancers, they can be very different subtypes. And you see this little drawing here of a stick, those little stick tumors coming off the fimbria of the tube. These cancers tend to have p53 mutations, BRCA1 or 2 mutations, and a lot of chromosomal instability. In contrast, a low-grade serous cancer, these low-grade cancers, may come from serous cystadenomas to progressively a serous borderline tumor, and then develop one of these mutations here, like a KRAS mutation, NRAS mutation, BRAF mutation, or HER2 amplification to develop into one of these low-grade serous cancers. And these often are classified as a type 1 cancer. So now let's get into what's really so important in how we can prevent further ovarian cancers from occurring and all these other reasons why we should undergo genetic testing. So we're going to discuss the who, the why, the what, and the future. This is a simplistic pie chart just showing the BRCA1 and 2 mutations and how common they are in ovarian cancer. BRCA1 germline and BRCA2 mutations that are germline, that means you inherited them. There are approximately 14% of women who have ovarian cancer. And then you see this word somatic. And these somatic BRCA1 and 2 mutations account for about 6%. That somatic means it occurs only in the tumor. And I'm going to show you some more information there. And then there's a whole bunch of other mutations here. And this side of the pie is all these homologous recombination defects. And I'm going to discuss that shortly. And I just want to show you this figure or this chart because it's important to recognize that BRCA1 and 2 mutations don't just occur in select types of ovarian cancer, but you can see here across all these types of ovarian cancer, these low-grade endometrioid cancers, either low or high-grade, clear cell, even carcinosarcomas can have BRCA1 or 2 mutations. So who should get tested? Well, the current assessment from several different leading societies say that all women with ovarian cancer should receive genetic counseling and be offered genetic testing, even in the absence of family history. So if you do have ovarian cancer, you should undergo genetic testing or see a genetic counselor. Some places don't have access to genetic counselors. I'm at Duke, and we're so lucky we have a fantastic hereditary cancer center program and genetic counselors and leading individuals in the field who really understand who should be tested and what tests to use. Well, here's the why. So why should you test? Well, we talked a little bit about BRCA1 and BRCA2 gene mutations. If you do have one of these mutations, it will provide you predictive information about how you'll respond to some of these new treatments, such as PARP inhibitors that you may have heard of. It will provide you prognostic information in terms of how long you can expect to live or how likely your cancer will respond to the chemotherapy treatments. And rolled up in all of that are a lot of therapeutic implications. It identifies cancer risk in other organs. So if you have ovarian cancer, you've been doing very well, or you have an early stage ovarian cancer, and you have this mutation that indicates that you're also at risk for breast cancer, and you may need to consider undergoing either screening for that, even some types of treatments to prevent it, or surgery. And then you can identify relatives that should also be tested, and that's known as cascade testing. So if you test positive for one of these mutations, then your daughters and sons should be tested, and potentially other family members. If you don't have this germline mutation, then you can avoid unnecessary surgical risks. For instance, no need to undergo prophylactic mastectomy or risk-reducing oophorectomy and salpingectomy, which means removal of the tubes and ovaries for that those last procedures, and mastectomy refers to removal of the breast. So we talked a little bit about germline and somatic, and this is just a figure showing what this really means. Germline mutations, you inherit them from a parent. They're all over your body. In every cell you have that mutation, including the tumor. In somatic mutations, that is an acquired mutation. You didn't inherit it from your parent, and they are only located in the tumor. If you want to detect a germline mutation, there's many tests that can be used to do that. They can be either blood or saliva-based tests to detect an inherited mutation. And tumor testing can now be done where we take the actual tumor, we send it off for analysis, and that can detect a mutation. And that mutation may be either somatic or germline. So when I have done this type of testing, if somebody has a positive test and they haven't had genetic testing and counseling yet, then I'll refer them to one of our counselors for those that counseling visit and testing. So what do you test? There's so much confusion about this. There's multi-gene panels, there's custom multi-gene panel, or BRCA1 or 2 only. There's a lot of arguments for various different approaches here. One of the pros for multi-gene panel is it uses virtually all these tests use next generation sequencing now, so it shouldn't be more expensive to choose a multi-gene panel versus BRCA1 or 2 only. You detect gene mutations beyond BRCA1 and 2, so you can look for mutations in other genes. They may not be as common, but it can still provide some information regarding risk and need for potential surgery or maybe even therapeutic implications. I listed some of those genes here, and you can assess for multiple genes at the same time rather than in sequence, so it saves time and maybe more efficiency. So what are the cons? Well, the results can be more complex. You can have these things called variants of uncertain significance, and even genes of uncertain significance. So I will relate to you, my own family history is riddled with breast cancer. And so my several relatives have had breast cancer at a young age, and they've gotten genetic testing. And we haven't identified a specific harmful gene that's potentially the cause of their cancer, but my my mom has a variant of uncertain significance. My sister has a gene of uncertain significance, and it doesn't make sense. So sometimes this can cause a lot of anxiety and confusion. And so you have this increased probability of detecting these mutations of uncertain significance if you do the multi-gene testing. There is a potential for misinterpretation of these results. If somebody sees a result, but it's a variant of uncertain significance rather than a bad mutation, they may recommend inappropriate surgery or screening. So I don't think there's any one right approach. It's a decision you need to discuss with your doctor or genetic counselor in order to make what's the correct decision for you. So why does it matter? Going into more of why should we do it? Well, as I mentioned, it's prognostic. So what this graph shows is that individuals who have either the BRCA2 or 1 mutation, that they tend to do better. You can see that this is what's called a survival curve. So this is their survival curve for the BRCA2 carriers. And it's longer than either the BRCA1 carriers or individuals that are non-carriers. And that's probably because women who have these mutations, while they put them at increased risk for the cancer, they're also more likely to respond to the chemotherapy. And this is a really simplistic view. Now we know that some of these non-carriers have other types of mutations that are also associated with what's called homologous recombination defects, and they may also be more sensitive to chemotherapy or other types of treatments. So this goes along with this whole idea of why does BRCA stats matter? Well, potentially therapeutic. So bear with me as we walk through the slide. This is figure of a DNA. You can see the DNA double helix here, and it's broken right here. It has a single-stranded break. And usually when you have a single-stranded break, your own body has this PARP enzyme known as poly-ADP ribose polymerase. That enzyme will come in and it will institute repair of this break. So right here, it's repairing this DNA. Now, if you give a PARP inhibitor, it will stop that process from happening. And you'll convert this single-stranded break here now into a double-stranded break of the DNA. Now, what happens in this situation, if you have a normal cell with an intact BRCA1 or 2 gene or functional homologous repair, and that's just a type of repair for the DNA that's very efficient, then the cell will survive, right? But if this PARP inhibitor comes in and causes this other additional break, and you have a BRCA1 or 2 mutation, then the repair may happen, but it'll be error prone, or in some cases, the cell won't be repaired at all, and your cancer cell will die. So this has really been, exploited in terms of treatment options for women who have BRCA1 and 2 mutations, because if you give a chemotherapy here and you cause a break in the DNA, and then you give a PARP inhibitor so the cancer cell can't repair its DNA, then you lead to cancer cell death. And it's a very exciting concept called synthetic lethality. Now, I will tell you it's more complicated than this, and they're finding out more and more about how these PARP inhibitors work. So we talked about how we can target DNA, and this is an example of where this drug called niraparib was used in women who had platinum-sensitive ovarian cancers that were recurrent. And this one group had germline BRCA mutations, and you can see that when they were treated with the PARP inhibitor after their chemotherapy, they had really long disease control. In fact, the drug was able to prevent disease progression by over 70%. And that translated to 21 months of median survival versus 5 months. This is a really simple way of looking at this. I'm going to show you some curves in a second to show you a different way to evaluate it. But you can see that across the board in all of these groups, you had benefit, right? If you can see here, this hazard ratio is 0.38, so you prevented the cancer from progressing by 60%. And here it's 0.545, so about 50%. But there's different magnitude of benefit. That means the amount that you got from the drug may vary based if you had a germline mutation or if you were non-germline mutation but HRD positive. And then this last group was overall non-germline mutation. Now we can dive into that more, and these are survival curves. So you're really looking at the amount of area under this curve, comparing it to this one. And here what you're seeing is HRD positive. Some people have asked, well, what does HRD positive mean? And it's really a biomarker, and I'll talk about that a little bit later because somebody asked that question. This curve represents individuals who have a somatic mutation BRCA. So they didn't inherit a mutation, but they have a tumor mutation, and how they had improved outcome with the drug. And then this last group, this group didn't have a germline BRCA mutation or HRD, but they also had some benefit, but not quite as much. And we see this again and again. So this is a trial called SOLO2 with a different drug called olaparib. And again, we see this really nice benefit if you continue to take this drug after chemotherapy once your cancer has recurred. And I hope you can understand these survival curves. I don't have a lot of time, but I'm happy to go over these again with anybody. And then lastly, I wanted to show the third drug, which is rucaparib, where we also see a nice benefit in terms of disease control if you have a mutation in BRCA, and this could be either a germline mutation or a somatic mutation. All right, so this has led to FDA approvals in all 3 of these PARP inhibitors here. And I just listed some of this information for you all, but the bottom line is it kind of heightens the idea of why testing may matter to determine if you're a candidate for some of these drugs. In this situation, if you want to get beyond 3rd line, you have to have a germline mutation. But in the maintenance setting, you can get these drugs even if you don't have a mutation in BRCA1 or 2, and even if you don't have HRD positive status. In this rucaparib indication, you have to either have a germline mutation in BRCA or a somatic mutation. And this is just a really exciting timeline of FDA-approved drugs for ovarian cancer. You can see this explosion of all these drugs being approved in the last 3 years, even from 2014. So we have olaparib, rucaparib, olaparib, and pembrolizumab most recently. So in summary, I hope that from the short period of time we've had together, you've seen that ovarian cancer overall is a rare disease, but so important for us to understand better, to prevent, to treat, and to cure. And that the classification of ovarian cancer is really evolving as we get more information about the underlying biology, what kind of mutations are present. Is it BRCA1, BRCA2, or something else that's responsible for some of the HRD positive cancers, and that survival is continuing to improve. I hope that you all recognize the importance of genetic testing for all women with ovarian cancer, that genetic testing may identify relatives that should get tested, known as cascade testing, that it can help identify individuals who need to be screened for other cancers or have preventive treatments or surgeries for other cancers. It can help with prognosis as well as predictive and treatment implications. And then my view of the future is that as time proceeds, we're going to enhance our understanding of individualized and personalized medicine, not just for ovarian cancer, but for all types of cancers, to help us in the goal for prevention, treatment, and cure. So thank you so much for your time. We do have some questions. And let me just... So one of the questions that just came up, and I'm going to close this out here. One of the questions that just came up, which is really timely, was one of the listeners has both BRCA mutations, and her gynecologist says that this is a blessing in disguise because of more treatment options. And yeah, it's really strange. It's kind of what we talked about in terms of if you have one of these mutations, it increases your risk of getting these types of cancers, but it also makes your cancers more sensitive to chemotherapy. And then if you add a PARP inhibitor, it may increase response to tumors because you have the mutation. And also, if you have a recurrence and then you're treated with chemotherapy and then choose to go on a PARP inhibitor for maintenance treatment, you may have a longer disease control because you have the BRCA mutation. So your GYN oncologist is really right. It seems odd, but even though it increases your risk of the cancer, it also helps you fight the cancer. We had some other questions too. One of the listeners said, is there a difference in these gene mutations among sisters? And if you had a sister who had a BRCA1 or 2 mutation, I would expect you not necessarily to have a different mutation. I would expect you either to have the same mutation or not to have the mutation. So if you're, the way that this works is you can inherit this from your parent, but you also have a 50% chance that you won't inherit it. So if your sister has the mutation, you should definitely get tested. If you don't have the mutation, it means you probably don't have the risk of ovarian cancer. It's probably close to the general population. It may still be a little bit higher, but most likely close to the general population. I would be very surprised if your sister had, for instance, a BRCA1 mutation and then you had a BRCA2 mutation. That would be odd, but it could be that you inherited different mutations from your parents. One of my partners does have a patient who has 2 mutations. She has a BRCA1 mutation and a BRCA2 mutation. Another question we had is a listener who is BRCA negative, so she doesn't have the BRCA1 or 2 mutation, but she's HRD positive. So HRD is definitely a different, it's a different type of test. It's evaluating a variety of different homologous recombination defects. And it is a test that's been developed by Myriad. And so you can actually go to their website. They have a wonderful educational website that provides this information. And what they've set up is this cutoff, basically, and they're looking at 3 different components that comprises HRD. And so if you have a cutoff of a certain amount, and I think the number is 42, if it's higher than that, then it's HRD positive. And when I see HRD positive, it makes me think of potentially some of these other gene mutations that can occur. So I showed it on one slide, but really briefly, but there are mutations like RAD51C, RAD51D, PALB2, BRIP1. So if you are HRD positive and you haven't had further genetic testing, i.e. a panel test, that's something you may want to explore with your physician or genetic counselor. We have some other questions here. Let me see. Here's some other really great questions. So this listener is BRCA1 positive. She had both ovaries removed, and she's in her 30s. And how much did that reduce your risk for breast cancer? From what I've read, it should be a 50% reduction. But please double check with your physician as well. And I know at Duke we have a separate breast cancer clinic, a breast hereditary cancer clinic for those individuals who are at high risk. But that's definitely something to review. Since you've had both your ovaries out, and I suspect that you've had your tubes out as well, your other question is, do you need a transvaginal sonogram? I have not been doing that for my patients who've had the prophylactic surgeries with everything removed. But there are some individuals that still recommend, for instance, CA125 testing. And I think the yield is so low that I don't advocate any further ultrasounds or CA125. But, I don't think that we have enough data to develop very firm guidelines. Another listener is BRCA positive and was wondering if she should be followed by a gynecologist or GYN oncologist. This is a loaded question because I'm a GYN oncologist, so I definitely don't want to say something that sounds self-serving. What I would recommend is that you have a discussion with your gynecologist regarding recommendations. Typically for individuals who are BRCA positive, we go through a thorough evaluation with these patients, their family history, a discussion regarding things that you can do to reduce your risk of ovarian and tubal cancer, such as oral contraceptive agents, screening with transvaginal ultrasounds and CA125s. There is a lot of promising new data coming out from the United Kingdom about using this algorithm, or ROCA, and CA125 testing over time. It's not ready for prime time yet, but we're all very excited about that, as well as pelvic exams. So in my view, I think it would be worthwhile to at least have one consultation visit with a GYN oncologist to review the recommendations. They'll also talk to you about your desires for fertility and when they would recommend that you undergo risk-reducing surgery. If somebody's BRCA1, we typically recommend that surgery be performed sooner rather than later, age 35, if somebody is completed their childbearing, and depending on their family history, when their first relative developed ovarian cancer can be helpful. Some patients, I've pushed this out to 40, but it does make me nervous. If somebody has a BRCA2 mutation, those cancers tend to happen later. So in women with BRCA2 mutations, I have counseled them about if they wanted to prolong their ovarian function, to wait until age 45, but we're following them very closely as well. And one of the most important things regarding ovarian cancers is understanding the symptoms. So if you have, I tell my patients, if you have symptoms that are recurring, such as urinary frequency, bloating, pelvic pain, pelvic pressure, feeling full early. Some things just may not be feeling right. If you have those symptoms that last 2 to 3 weeks, call me. Don't wait for your next visit, but give me a call, because some of these cancers may not be really amenable to screening, and that's the hard thing with ovarian cancer. Even though we have some screening techniques, they're not great. If you are listening, it's probably worthwhile to have that discussion. I do want to mention one more thing regarding the surgery. There's a lot of interest now that if it's coming from the tube, can you just remove the tube and leave the ovary? Maybe come back and get those ovaries later. I think it's a fascinating idea. People are studying this concept globally, and we don't currently have a clinical trial in the United States, although one was proposed. I wish we did, because I think it would be a really important study to complete. But essentially at this junction, I have not been offering that to patients because we don't have any data to support it yet. But if there was a clinical trial that somebody could participate on and they were addressing this question, I would think that would be totally fine to do. I just have some hesitation in doing it without more information. And let's see. I know we had some other questions I can probably go to. I have to pull up the folder and find it on my downloaded page here. Meg, I know you can probably hear me. Do you have any of those other questions you can share with me from the listeners?
Hi, Dr. Secord. Let me just grab a couple of those questions. I think that thank you so much for answering our questions so far. Let me just grab that really quick.
Thank you. I downloaded it, but I can't find my download button, and I don't want to come off the Google Chat.
I totally understand. No, that makes sense. Okay, just one second. Let's see. And I apologize if you've covered some of this already, but one of the questions we had, and someone just submitted live too, is are you familiar with the iCare Inherited Cancer Registry? And are there any downsides to registering with an organization like that?
Oh, I'm not familiar with that registry, but if you get that individual's information, I will try to find out more, and I can connect back with them when I do.
Okay, great. I will do that. One of the other questions we had, are you aware of any clinical trials focusing on the TP53 mutation in ovarian cancer?
Yes, there's been several clinical trials trying to target P53 or TP53. That is a very common gene mutation in high-grade serous cancers. And some reports is, over 95%, some say 98%. But at any rate, there was actually a gene study I would participate in when I was a fellow in the 99 to 2001. But it's been very hard to target. And then some of the more recent clinical trials have been with agents that target WEE1, basically another factor in that P53 pathway that have shown some promise. So it's kind of an off-target way to get at P53. And then there's a new drug that's currently out targeting P53 as being developed as a clinical trial, and we're hoping to open that at Duke. It's in our pipeline. So in that study, if somebody has a recurrence, they either get standard of care chemotherapy alone versus the chemotherapy plus this drug that targets TP53. So certainly a lot of excitement there, because if we find a way to target that P53 mutation, which is so prevalent in high-grade serous ovarian cancer, we may really be onto something.
Okay, great, thank you. Another question that came in is this woman is asking, since I have both BRCA mutations, I wanted to have my breast done. I assume she means prophylactic mastectomy, but she says she's afraid to go off the PARP inhibitor to have that surgery. And she wants to know, will the PARP inhibitor also help prevent breast cancer possibly?
I am not absolutely sure if it will, but from a hypothetical standpoint, I suspect that it will help prevent breast cancer. You know, I share her concern. I think that with the data I've seen with PARP inhibitors, people can do really well for a long period of time. And then I wonder if you take that pressure off, what could happen. And there's also this concept of BRCA mutation reversions, where the mutation can revert back so it functions normally for homologous recombination. So at this junction, it sounds like she is fairly well-controlled disease with the PARP inhibitor. I don't know all the details, but I would hold the course. And for your breast cancer screening, I would recommend talking to your breast cancer doctors, but one thing you could do would be alternating breast MRIs and screening mammograms. So that's a really important discussion to have. Thanks for having me. I know we have to go in interest of time, but if I can help anybody else with any questions, I'm happy to. Just let me know.
All right. So thanks again, Dr. Secord. That was great. And we might follow up with you with a couple other questions. And so for the second part of our web chat today, Katya Lezin, patient advocate and ovarian cancer survivor, will share her experience and insight on the rapidly changing field of genetic testing. Now, Katya's indoctrination into the world of hereditary cancer came when she was diagnosed with ovarian cancer in 2011, followed by a recurrence in 2013. And even though the extent of her Jewish lineage is a keen appreciation for a good bagel and lox, Katya is enough of an Ashkenazi Jew to inherit the BRCA1 genetic mutation. Now, Katya, we really appreciate you being here today to share your experience with genetic testing in ovarian cancer, and I will now turn the presentation over to you.
Okay, well, hello everybody. And as she mentioned, I am a two-time ovarian cancer survivor. So I'll just pause there to say, for those of you who are kind of in the thick of the fight, know that I've been through it twice and I am enjoying a very full and happy life right now. So you can do this. And I'm also a BRCA1 carrier. So for purposes of genetic mutation, kind of the time frame is pre-Angelina Jolie and post-Angelina Jolie. And, you know, because it really wasn't on, I think, the national radar until she went public with her own surgeries and her own mutation. And so I was diagnosed pre-Angelina Jolie. So I'd never heard of BRCA. I'd never heard of mutations. I found out I had ovarian cancer. I actually manifested in a somewhat unusual way. I had rectal pain, so none of the symptoms that the doctor just mentioned. But as we all know, even those symptoms often go misdiagnosed or undiagnosed because there aren't a lot of middle-aged women I know who don't have some of those. But I had extreme rectal pain, and it turned out that one of my ovaries had twisted and descended and was causing pain in my rectum, and that's how I found out I had ovarian cancer. I always say that my butt saved my life and sounded the alarm. And so when I met with my gynecological oncologist for the first time, you know, I know many of you know this well, that, you know, your mind's just reeling from the diagnosis and just trying to get your head around what it means. I know when I was told I had ovarian cancer, I kind of did that mental Rolodex in my head and thought, well, I don't think that's one of the good cancers. And then I looked it up online, and I have a distinct memory of slamming my laptop shut because the numbers were pretty grim. And so I'm meeting with the gynecological oncologist for the first time, and I'm sitting in the exam room, my husband and I, and, you know, we're just trying to get our heads around. We'd kind of heard there would be a peritoneal port and just trying to imagine what that's like and what the chemo regimen would be and how we could handle, you know, the interruption to our lives. And the oncologist walks in, and before he's even said hello or greeted me, he walks in the room and he just says, "Are you Jewish?" Now, mind you, I had never heard of BRCA, and so I thought this was a very bizarre question. And I'm kind of thinking, are you not going to treat me? Like, you know, and I'm kind of formulating my answer of, well, I wasn't raised Jewish, but I know a good bagel and lox when I see one, and I married a Jew, and the kids are a work in progress. He didn't want to know any of that. He wanted to know, are you of Eastern European Ashkenazi Jewish lineage? Because he thought it was highly likely that my cancer stemmed from a genetic mutation. And he was right. He already had two big red flags. As she mentioned in her comments, the doctor, that, you know, ovarian cancer is its own red flag. I think 1 in 4 ovarian cancers stems from a genetic mutation, and it is its own red flag as far as testing goes. Any ovarian cancer at any age warrants testing. I also was 45, which is young for cancer, and that is a red flag. And then the Ashkenazi Jewish piece was just the final nail in the coffin. And when I told my dad actually that it came from him, he was like, "But I was never bar mitzvahed." And turns out that doesn't matter with respect to the gene. The rabbi might care about that, but the gene, not so much. So one thing that I've come to appreciate is that I was told you need genetic testing, and it was done right then and there. And I don't recall having a lot of say in it, which I appreciate, because I wasn't there yet to fully comprehend how much of a stroke of luck that was within the realm of bad luck of having cancer. The fact that mine stemmed from this genetic mutation was actually really good luck. And I appreciate that the expert to whom I had entrusted my care saw that and just treated it as part and parcel of my care. I need your weight, I need your blood pressure, and you need genetic testing. And when I found out that I was BRCA1, I'll be honest, I just had a little pity party, like, how unlucky can I be that I not only have cancer, but I also have this horrible genetic mutation. And I've totally changed my tune. And I just want to share with you all the kind of 5 positives that stemmed from that initial, what felt like bad news. So the first thing that happened when I found out that my cancer stemmed from BRCA1 was that it kind of answered the inevitable why me. When you're diagnosed with a catastrophic illness like ovarian cancer, I actually found it helpful to have a scientific explanation. I find science comforting, and it was better for me than feeling like cosmic bad luck or the universe was out to get me. And I pretty quickly realized that that same information that helped me just kind of get my head around it was going to be definitely helpful to my medical team in terms of treating me. That how could it not help to understand how and why my cancer came about? And I do believe that a lot of these advances that are keeping a lot of us around stem from knowing how and why the cancer came about, so that these therapies can be personalized and targeted and can advance with that knowledge. The second thing that happened is that, as she mentioned, that kind of like the same mutation that is responsible for us getting the cancer also helps us respond to the treatment for the cancer. So, BRCA1 gave me cancer, boo, but because of BRCA1, I'm going to respond better to the treatment, yay. So once you already have the cancer, then that's nothing but happy news and good luck. It turns out that my type of ovarian cancer responded better to the chemo regimen of Taxol and cisplatin, and to the way it was administered through a peritoneal port in my abdomen, because of the fact that it stemmed from the BRCA1 mutation. I don't really get the science of it, but my kind of layperson understanding of it is that the same mutation that made the cells form cancer also makes them less able to fight cancer-fighting drugs, because, as she mentioned, it's a breakdown in the repair pathway, and they can't repair themselves as well. So that was really, really good news, because back to those really grim statistics I saw, that allowed me to kind of put a wedge between me and those really grim numbers, that, there was something to hang my hat on, that those didn't necessarily have to apply to me, and that this grueling chemo regimen that I was on following the hysterectomy that I had, was not just buying me a little extra time, but that I could actually beat this thing. The next way that it played out as a positive for me is that it let me know my odds of getting other cancers. So I already had the more unlikely of the 2 cancers associated with the BRCA mutation. It's still a very high percentage compared to the general population. So it's a phenomenal diagnostic tool for a cancer that's otherwise so hard to detect. But I already had ovarian cancer, so that ship had kind of sailed. But I found out I had an 87% chance of getting breast cancer. I didn't like those odds. I felt like I had already lost the cancer lottery, and I didn't want to take my chances. And so I elected to have a prophylactic double mastectomy. I know that's an agonizing decision for some women. For me, I have to say it was a no-brainer. I had very large breasts. I had breastfed my 3 kids, but I was like, now you might try to kill me, bye-bye. And so I elected to have a DEEP, which is when they take the fat from your stomach to make your new breasts. So if you're looking for your silver linings, I got a free tummy tuck. And that surgery cost $96,000. And I paid not a penny, because when I went to my insurance company and said, this is what I want to do, they said, where do we sign? Not out of the goodness of their heart, mind you, but because they knew my odds just like I did, and they didn't like them any more than I did. And they knew that as expensive as that surgery was, it was a lot less expensive than treating me for a cancer that I was very likely to get. So I think that's a huge practical plus that's really important to keep in mind, that whatever measures you take to protect yourself if you have this mutation will now be covered by insurance. And I get that, you know, for some women, these prophylactic surgeries might be extreme, or it might not yet be the time for it in their life. You know, I was 45 in a happy, stable marriage and already had my 3 kids. I'm going to respond differently than someone who's maybe in her early 20s. But whatever measures you take, you know, any thing that's above and beyond the normal protocol, up to and including these surgeries, will be covered. So, you know, diagnostic MRIs, more frequent mammograms, any kind of heightened scrutiny is something that you now, you can take these measures to protect yourself, and you don't have to do so out of pocket. So I think that's a huge practical plus of the genetic mutation. So the doctor mentioned the PARP inhibitors, and that's the next way that this kind of plays out in my journey, because as I mentioned, I'm a 2-time ovarian cancer survivor. So my cancer did come back. I was just shy of making it to the 2-year mark, which is a pretty important milestone for ovarian cancer, and my CA-125 started creeping up. So I had this kind of horrible limbo state where it was kind of irrefutable that it was back, but we couldn't find it. And finally, a PET scan showed a lesion on my spleen. And so I was told I needed a splenectomy. I'm kind of running out of body parts to remove, but okay. And my oncologist said that he would look around when the splenectomy was done to see if the cancer was elsewhere that he just couldn't see on the images, because I was having a lot of nausea at the time. And so he said, if it is, you're going to need to do some chemo. And the chemo regimen for recurrence of ovarian cancer is a PARP inhibitor. Now, this was November of 2013, not that long ago, but PARP inhibitors were not FDA approved. So I was going to have to undergo the logistical, financial, and emotional upheaval of being treated away from home. And I always say the only thing worse than being told you have cancer is being told you have cancer again. And the only thing worse than being told you have cancer again is, and by the way, we can't treat you at home. Now, luckily, when they went in, the surgical intervention took care of all visible signs of the cancer, and I didn't need that PARP inhibitor. But now that PARP inhibitor is FDA approved. And it's FDA approved because of the partnering diagnostic tool that is the BRCA test that Myriad developed. And what that means for me is that I can have peace of mind and put cancer on the back burner and live my life, because if it does come back, and I know everybody's got a different way of kind of processing and approaching this, I kind of think of my ovarian cancer as a recurring chronic disease. That my dad has asthma, I have ovarian cancer, and I can live my life and put it on the back burner, because I know that if it does come back, I now can have this chemo regimen that's a PARP inhibitor that does all the amazing things she mentioned earlier, that she can do the science much better than I can. But what I know is it just represents hope. And it's a matter of pills now. So, you know, it turns out the only dainty part of my body is my veins. I don't have to have it administered intravenously, and I can have it at home. So it's much less of an interruption on my life. And then the final piece of good news, and I've definitely saved the best for last, and this to me is what warrants testing more than anything else, is that this is a gift that I'm giving my kids. And I think everyone who gets tested is not just doing it for themselves, but doing it for loved ones in their life. I feel like I took one for the team so that my kids don't have to. And, in the last 6 years, I've had 7 major surgeries. I've had 10 overnight hospitalizations. I've had the removal of multiple body parts, hair loss, you name it. And I don't know any parent who wouldn't want to spare her children that hell. So I have the means of doing that. I'm giving them the gift of knowledge so that they can be previvors versus survivors and take whatever measures they need to take to reduce or eliminate their risk of cancer. So I have 3 children. My son is 23, and boys obviously should be tested as well, because he could be a carrier, and there's a slightly increased risk of male breast cancer and prostate cancer, but it's not on his immediate radar, so he's going to wait a little bit, but he will be tested. My youngest daughter is 17, and she just started college, and I just feel like she's got enough on her plate right now, so we're going to wait a little bit. But my 21-year-old daughter did just get tested, and I'm sorry to say that she too is positive. And I'm not going to lie, I was sad. I wish we didn't have this in common. But what I really wish we didn't have in common is cancer. And so this is actually the best thing that she can do for herself to avoid fighting cancer the way that I did. And there are lots of things she can do just as a 21-year-old. She can be on the pill to reduce her risk of ovarian cancer. She can start doing self-breast exams and just kind of let her medical team know. At age 25, she can start having diagnostic MRIs. And as the doctor mentioned, you know, she'll want to start her family sooner rather than later, so that at age 35, she can start thinking about some of these prophylactic surgeries. When she texted me that she was positive and I texted her back and said, "How you doing?" Her response was, "Well, now I really got to get me a boyfriend." So that just kind of shows that she's not traumatized, and she too just sees it as, you know, a little complication in her life, but ultimately saving her life and empowering. And that's really how I feel about genetic testing. So thanks for letting me share my story, and best of luck to all of you listening.